Good morning. How are you?
Good morning. Pretty good. How are you guys doing?
I'm good. I'll turn off now that audio and video are
Hi,
working.
Good morning. How are you doing?
I'm good. How are you doing?
Oh, pretty good. Very good.
Where are you guys?
Can you see us?
Yeah, are you in Michigan or
Yeah,
where?
yep, Michigan.
Yeah.
What town?
I'm actually in Lake County in Irons, or excuse me, Baldwin, the other side of the state by Lake Michigan.
Oh, cool.
And I'm in the Ann Arbor area.
Oh, good.
Yeah.
In
Okay.
just a moment, we'll get started.
Okay.
I'm just making sure all of our that's in here. We will have and I don't see her logged in yet. We will have an ASL translator. So I'm just giving her a moment to log on.
Okay.
And I know Dr. Sequelae was going to jump on at 10 as well. So she is
Okay,
planning on coming for the whole portion. Yep.
awesome. Okay, then I'll just give a few minutes here for everybody to log on. And good
What?
morning to everybody that's watching. I'm so excited about this. So just give us a few minutes and we'll get started.
Great. Can I just play with the share screen, see if it works?
Yeah, go right ahead.
Okay.
It should
Oh,
it should work.
nope.
Okay, let me look at the advanced settings here, make sure. Okay, now it should work.
That should work. Okay. Yep.
Okay,
Good. See?
yep, there we go.
Okay. Now, presentation. Whoops. What do you guys see now?
I see it shows the entire presentation, like on the initial screen.
Okay, that's good, right? Yeah.
Okay, oh yeah.
Okay.
I'm gonna go ahead and get started. Our I haven't heard from our translator that she's not coming, but I don't see her on here and I haven't heard anything. Um, I'm just double checking real quick to make sure there's any messages sent to me.
Okay.
But she can pick as soon as she steps in, she can pick up where we're at. Um,
Okay.
so I am very excited about this today. I've had leading up to this, could not wait for this moment to happen. So good morning and welcome to the first day of Let's Talk Long COVID webinar series brought to you by Disability Network West Michigan. My name is Marisa Salisbury and I will be your moderator. Before we get started, just a few housekeeping tidbits. Each day of the webinar series is recorded, and you would have heard that recording message as well as a reminder when you logged on today. Although everyone is muted, if you are encouraged to ask questions. Time permitting, we'll have a Q&A at the end of every presentation. So in the bottom of your screen, the Q&A, please feel free to enter in questions regarding the presentations, of course. After the webinar series has concluded, a list of resources and or references will be emailed out to you. So expect that later on this week. I wanted to let you know that captions are on. However, you can turn them off at any time on the bottom of your screen. So for your personal view, all you have to do is go to the bottom, hit the button for captions, and it turns them off for you. I want to mention real briefly, as a public health professional, I've been part of this COVID process from the beginning. I was part of contact tracing when everything had started back in 2020. And I'm currently looking at the effects of COVID on communities so we can help people prepare emergency plans. So I am incredibly excited at the leaders in science and advocacy that are speaking over the next 2 days. So as a CIL, or Center for Independent Living, one of our services at Disability Network West Michigan is to provide education opportunities. We are excited to offer this webinar series, bringing experts at the top of their fields in research, clinical sciences, veterans affairs, and advocacy into your offices and homes to help provide up-to-date information about COVID, the post-COVID condition, or PCC, also known as long COVID. The information provided during this two-day virtual event will be geared towards both professionals in healthcare and public health, as well as community members that do not work currently in healthcare or public health. Today, we're going to see presentations from Dr. Walter Koroshetz, Dr. Catherine Sequelae, Becca Squires. Their presentations will talk about what is PCC, how has research helped navigate the long-term effects of post-infection of SARS-CoV-2, and what does a post-COVID clinic look like, and how what we have learned from diseases like lupus could help us mitigate or manage the symptoms of long COVID. I would like now to present our first speaker, Dr. Walter Koroshetz. Dr. Koroshetz serves as the director of the National Institute of Neurological Disorders and Stroke. He joins NINDS in 2007 as a deputy director and has held leadership roles in a number of NIH and NINDS programs, including co-leading NIH's Brain Initiative, the NIH Recover Initiative in the study of post-acute sequelae of COVID-19, NIH Blueprint of Neuroscience, the NIH Post-Acute Sequelae of COVID-19 Initiative, the Traumatic Brain Injury Center collaboration between the NIH Intramural and the Uniformed Health Services University, the Helping to End Addiction Long-Term or HEAL initiative. He co-leads a number of NIH Common Funds programs, including the Undiagnosed Disease Network, the Acute to Chronic Pain Transition programs, Somatic Gene Editing Program, Transformational ALS Research Program, and he was instrumental in founding the NIH Office of Emergency Care Research. Before joining NINDS, Dr. Koroshetz served as Vice Chair of the Neurology Services and Director of Stroke and Neurointensive Care Services at Massachusetts General Hospital, or MGH. He was a professor in neurology at Harvard Medical School, or HMS, and leads neurology resident training at MGH between 1990 and 2007. Over that same period, he co-directed the HMS Neurobiology of Disease course with Drs. Edward Kravitz and Robert H. Brown. The MR spectroscopy in Huntington disease, diffusion, perfusion, MR, and CT X-ray, a native of Brooklyn, New York. Dr. Koroshetz graduated from Georgetown University and received his medical degree from the University of Chicago. He trained in internal medicine at the University of Chicago and Massachusetts General Hospital. He then trained in neurology and neuroscience at MGH and Harvard Neurobiology, focusing on how synaptic mechanisms might contribute to neuronal death. His early research in the lab and clinic focused on Huntington's disease, and with the team at MGH performed the first study of pre-symptomatic testing based on linkage analysis. A major focus of his clinical research career was the development of measures in patients that reflect the underlying biology of their conditions. This led to the development and validation of image techniques, including magnetic resonance, or MR spectroscopy in Huntington's disease, diffusion, perfusion, MR, and CT X-ray angiography and perfusion imaging in stroke. These stroke imaging tools are now commonplace in stroke care. Guided by these tools, he pioneered acute clot removal for acute stroke patients with large artery occlusion, which is now practiced at comprehensive stroke centers around the country. Through his work with the American Academy of Neurology, American Stroke Association, and ACGME, he played a significant role in the revolution in acute stroke care in the US and the growth of neurointensive care field. Welcome, Dr. Koroshetz.
Thank you very much. Yeah, so I'm real pleased to be here today to talk to you a little bit about long COVID and what's going on at NIH. What do you think is the best kind of time frame for me to keep to in terms of giving a presentation? You guys have any thoughts there?
Well, about 20 to 25 minutes is fine, and we can have, yep.
Good. Okay, great. So I guess the first thing I have to start off with, talking to folks in Michigan, is to put the Go Blue sign up, which I got from my last visit to University of Ann Arbor. And but yeah, the problem we're talking about today is a significant one. It affects definitely hundreds of thousands of people, um, and um, and it's still quite a mystery. So we have a lot of work to do. Uh, and let's see. I'm guessing you're not seeing the slide this time.
No, I can see it's the intro, like the full presentation that you see when you first go into PowerPoint. Yep.
Okay, great. Okay, great. So I'm the director of the Neurologic Institute, and I work with the director of the Heart, Lung, and Blood Institute and the National Institute for Allergy and Infectious Disease on long COVID. And so as we all know, the epidemic that came created tremendous morbidity and mortality. There was involvement of multiple different organ systems in the acute infection, and the biggest challenge that we were working on early on was trying to figure out how to get people to survive this critical care illness and reduce the mortality. And what people developed is a severe respiratory problem, which was similar to what we call adult respiratory distress syndrome. We had seen that before with SARS-CoV, other outbursts of that infection. And we knew that people who undergo this kind of severe illness are going to have a long recovery period. And so clinics started up around the country to take care of people coming out of the intensive care units. But the big surprise was that these clinics filled up with people who were never even in the hospital, who developed symptoms related to their COVID infection, even though it was mild, and that was kind of a surprise to everyone. Now, the problem is that it's still a condition that is defined based on the symptoms and their tight temporal correlation to when you got COVID. There is still no test for long COVID, so it's really a symptomatic syndrome-based diagnosis right now. There is an ICD code that physicians can use in billing and registering folks as having this condition. But there's a whole bunch of things that people complain of. And when this first came out, there were, social media uh, uh, surveys of large numbers of people, and there were a list of almost 100, over 100 symptoms that people could have in this post-COVID period. And they involved the lungs, particularly cough, shortness of breath, diabetes in the pancreas, chest palpitations, postural orthostatic tachycardia syndrome, abdominal pain, diarrhea, constipation. There were a lot of neurologic issues, cognitive impairment, sense of fatigue, disordered sleep, memory loss, buzzing in the ear, trouble with the autonomic nervous system, and pain, and sometimes what seemed like a nerve problem called a neuropathy. And then in the acute phase, it affected the blood vessels because the lining of the blood vessels contained the receptor for the virus. So when you got infected, if it got into your bloodstream, it would affect these blood vessels and cause clotting troubles that could lead to stroke, heart attacks, or lots of other problems in different organs because of the blood supply and the clots in these small blood vessels. So I'm a neurologist, and so every different institute will talk about their own special organ. We're interested in the brain, and I think importantly, as you look now at the long COVID, the brain problems, particularly the cognitive troubles that people are complaining of, are the ones that are sticking the longest and causing the most trouble. So one question early on was, can the virus get into the brain? And the answer is we don't know exactly, but not in a big way. What we do know is that the virus infects the cells in the nose, and that's why people would lose their sense of smell, because it would damage those sensory organ in your nose that allows you to smell, and it's involved heavily in taste as well. But the concern is that the way that your smell gets to your brain is through these little nerves that go from the nose right into the brain. And so there was questions about whether the virus was going through these nerves into the brain. So you can see here in a study where they show a lot of people with infection in the nose, but when you get to the first stage in the brain called the bulb, there's very little. And then if you go further back, even they only found one incidence where it would look like there was virus in the brain. And these are very kind of low titers, and it's possible that other people have not been able to replicate this. So I guess the good news is if it's getting into the brain, it's not a major source of the infection. However, as I mentioned, virus does affect the blood vessels, and that includes the blood vessels in the brain, and that's where the brain could suffer. So in studies of people who died with COVID, the people here at NIH found that the blood vessels were leaky. The blood's supposed to go through the brain. It's very controlled what gets out of the blood vessels into the brain. And there was a breakdown of that barrier, and there was leakage of fluid from the blood vessels, usually the very tiny blood vessels, into the brain. And that set up a reaction in the brain called inflammation that responded to this leakiness of the small blood vessels. And that was the cause of a lot of the cognitive troubles and the neurologic troubles in the acute COVID space. And now what we're faced with is there something that's going on in the brain that happened when you got acutely infected, but got set up by this leakage, and then you get inflammation, and the inflammation is still present. So that's one of the things that we're worried about. And I'll talk to you a little bit about what the evidence is. It's still shaky at this point, but it is still an area of concern. Now, the one thing to mention is that if you look at the symptoms that people with long COVID had, and then you look at the symptoms for what people with what's called myalgic encephalomyelitis chronic fatigue syndrome have, otherwise known as ME/CFS, there's a gigantic overlap. And as time goes on, that overlap just gets stronger and stronger and stronger. And so what is ME/CFS? And basically, ME/CFS is thought to be a infection-associated chronic syndrome. And so people would have Lyme disease, or they would have Epstein-Barr virus, and they would feel fatigued, and they just never got better. It's been terrible. It's a really terrible condition. Some people, once they got this, they couldn't get rid of it. They spend decades impaired because of this severe fatiguing illness. And they have a lot of the things that people with long COVID have: trouble with memory, concentration, executive function, trying to figure out what do I do in the next 2 minutes, 3 minutes, 4 minutes. How do I put all the things I'm thinking about together to get to a logical presentation? Those are what we call executive functions of the brain. Sleep disorders, pain, syndromes, headache, and postural orthostatic tachycardia, whereas defined by, when you go from a lying to a sitting position, your heart rate just goes sky high, and you get this real sense of anxiety. And these folks have a lot of fatigue as well. The one,
Doctor, I hate to
yeah,
interrupt you. Can you
yeah,
advance to the slide that you're currently speaking of? We're
okay.
still seeing at the very beginning.
You're seeing the very beginning. Oh, that's
Yep.
interesting. Well, let me, not sure what to do here. Hold on one second.
Okay.
I'm seeing a different slide. Let me stop share. Okay. Move it over here. Maybe that works. Gonna share again.
Okay.
All right. All right. What do you
There
see
we
now?
go. I see NIH Recover Scope comprehensive and synergistic deliverables, excuse me.
Okay,
There we go. Thank you, doctor.
all right, so um, let me see what happens here. If I go to full screen, what do you see now?
I see post-acute sequelae of COVID-19 symptom clusters overlap with ME/CFS.
Okay, and now did it change?
Yep, and yep.
Okay.
Yep.
All right, let's go back to, so we're basically talking about this slide here and the overlap between ME/CFS and long COVID. Now, I'd say that our institute and the National Institute of Allergy and Infectious Disease has been working on ME/CFS for a couple of decades, and no one's been able to figure out what causes this chronic illness in people who've had an infection and then never get better from it. So we got worried right away that long COVID and ME/CFS are going to be something very similar, and that is a challenge because we haven't been able to figure out what causes ME/CFS. So what we did was we put together a research project that was built on the guess that this is going to be a really hard problem to solve because no one's been able to solve it before with other infections. And so we thought that if we guess wrong and it's going to be something simple, somebody's going to figure it out quickly and we can just stop and go on to something else. But the idea was that this might not be easy to solve, and so we would put together something on a really large scale so that we would not leave any stone unturned, that we'd be looking everywhere we could possibly look at to try and get an answer to this problem, hoping that someone else is going to get it quicker, but this is kind of the backstop in case that doesn't happen. So I just wanted to put that out there. And so what we decided to do is to develop a program that to try and understand what is the biological driver of this condition called long COVID, and for other things, it's infection-associated chronic illnesses. Define the risk factors, the incidence, the prevalence, study what happens over time, and then try and identify interventions to treat and prevent it. So we put together groups of patients, people with experience in ME/CFS, infectious diseases, a variety of different organ systems. As you saw, so many are involved. And we built a program across the country with over 30 research hubs enrolling people who have long COVID or who have an acute COVID infection so that we could follow them and compare the people who got better from the people who developed long COVID. So that can only be done while the pandemic was going on. We thought that was important to do because it was a time-sensitive ability to look and compare how some people get better and some don't. We put together a group that could look a lot at electronic health records. They had access to 60 million patient records, 60 million patients and their records to be able to do these kind of machine learning AI-like looks at large databases of medical records. And in our enrolling people, we went after adults, we went after kids, we went after women who were pregnant when they developed the infection. We also went after people who had died and donated their tissues so that we could look to see under the microscope what's going on in people who have long COVID. Because some things you can test by looking at blood tests or scans, but there's a lot of investigation that can only be done, under the microscope, so to speak. And there you need tissue. And because it was so common, we thought there will be people dying, not necessarily of long COVID, but they'll die for other reasons, and they have long COVID, and that would give us an opportunity to try and investigate what's going on in the body of people who have long COVID. So this was a gigantic effort, and 60 million people. We also funded investigators around the country to try and understand different pieces of the long COVID, like the cognitive trouble or the clotting trouble, the immune problems, and that all went on and actually went very quickly. Um, and the reason why it could go so quickly is because we had funding from Congress. We got $1.15 billion from Congress, so we could set up these hubs and get investigators to start bringing people in. And the other reason is because it's so prevalent. That so this is old data now, but at one time, at least 6.9% of the people were currently experiencing long COVID who had ever had COVID. And we launched this initiative to study it in 2021. In about a year, we enrolled almost 15,000 people with long COVID. And this just gives you, this is from a study done around the world, actually, looking at the differences between men and women. And you can see here that that women are more preferentially affected than men. And these are the symptoms that people have. Most people with long COVID have multiple symptoms, probably on average have 7 different symptoms. Fatigue is the biggest one. Respiratory trouble was very big, particularly in the beginning. And then there's a condition called post-exertional malaise. Now, post-exertional malaise is defined by, just in simple terms, is a condition where people who are feeling fatigued, they have good days, they have bad days. On a good day, they might do something like go out to the store and go shopping. So not talking about real exertion, but something like going to the store and where previously they felt too fatigued. If they do that, then for the next 2 or 3 days, sometimes even longer, they're completely wiped out. They can't even get out of the house. That's, kind of a definition of post-exertional malaise. And that was the signature of MECFS for years. That's been the signature thing where not many other people have that. But what we were seeing that that was not uncommon. Not everybody with long COVID had it, but there were a significant number of people with long COVID who had that post-exertional malaise, which then brings in that tie again with MECFS. Now, some of the symptoms, what you can do with the electronic health record is you can look at people, health records over time and see from the time they had a COVID diagnosis, what else popped up in their medical record. So you can see things here like headache popped up, back pain, chest pain, stomach pain, painful muscles, tingling in the extremities a little bit. And these are the kind of studies that people were doing, and we were able to, link because of the temporal association with when people developed COVID. Now, a lot of these things, they came and they went. It might take, 50 days, 100 days to go away. Some of them, like painful muscles, and some people, they're not going away, they're staying. And so that gets you into the problem of it's a moving target. What long COVID is, a moving target. It's changing over time. We still don't know where it's going to end up. So this is looking at people who have these symptoms we talked about between 30 and 80 days, so between 1 and 6 months. And now you're looking here between 180 and 360 days. So this is out to a year. And what you can see if you look at the red bars and the blue bars here, and then you look here, what you see is that they are getting better over time. So the bars are longer at the 1 to 3 months than they are at a year. And you can see the red, generally the red of the females, and they're generally, the bars are higher than the males. And things that are persisting are trouble with breathing, concentration, memory, feeling of weakness, and a whole bunch of other things in smaller numbers of people. But given the fact that there were so many people affected with COVID, even if a small percentage have trouble, it's still lots and lots of people. But the good news is that people do get better from long COVID. At least some people get better from long COVID. We don't know if there are going to be people who develop this ME/CFS that never get better, but that would be a big concern. What we did in the recover program is we looked at all the patients we had. We had over 15,000 patients. These are the adults. And we looked at a set of symptoms. And as I said, people usually don't have one symptom, they have multiple symptoms. And what we found was these symptoms are pretty common in the general population, but if you combine them, that's not so common. So we developed a score whereby, for research purposes, if people are having uh, a whole bunch of different symptoms, you give them a score for each particular symptom. You add the scores up, and people are having a score that's greater than 11. That's something that's really unusual. That's almost certainly clearly related to their to a long COVID syndrome. And you can see here the smell and taste. That was a big one because that's associated with COVID for sure. And then that post-exertion malaise, that was the second highest symptom that would push people into a long COVID diagnosis. But then there's a whole bunch of other ones: chronic cough, brain fog, thirst, palpitations, chest pain, fatigue. So that's what we did. And this is good for research. It's not really that good for individual patient diagnosis, though, because a patient, there's so much variability in what a patient can present with. But we did find, in looking at our electronic health record studies, that there was a big effect of being vaccinated on cutting down your chance of getting long COVID. And then I want to talk a little bit about what we think might be going on. But as I said, we don't know exactly what's going on yet to cause this chronic illness. These are the main theories. One is that it turns out we have lots of viruses in our body that we never get rid of. COVID could be one of them. So it could be a persistent viral infection due to the virus. It just really doesn't go away. It's hiding somewhere in the body. Can't check it out in your nose anymore, but it's somewhere else. The other thing is, when you have an infection, these other viruses that we've had before, they've been sitting in our body and they've been dormant, but they can get activated when you have an infection. So one possibility is that COVID activated another virus. One of the big, culprits here is Epstein-Barr virus, which causes infectious mononucleosis. That's a virus that's always in our body, and it gets reactivated when we have infections. And the other one is that the immune system was pushed to respond to the virus, and it kind of pushed it over the cliff, and now your immune system's not working normally. It's not resetting, and that's the other main theory that's out there. Now, we don't know exactly yet, but we did have early on a study from NIH which showed that people who died with COVID could find virus in the body out 280 days, so almost a year out after the infection. And there have been multiple other studies that are also showing evidence that there is persistent virus in the body. And so that would go with that first theory of the COVID coronavirus is still in our body somewhere. And so our first trial was to use extended Paxlovid, which is the antiviral agent, on the hope that it could eradicate any pools of dormant coronavirus. And if the virus is still in your body, it could potentially still be activating the immune system. And so you never feel good again because you really always have some infection and immune reaction to that. So this is still being worked up. We're getting more tissue. We're doing more studies. We're trying to figure out if we can discover it in, say, in the stool, in the GI tract is where a lot of people are finding it. Whether we can see it with a diagnostic test of the stool or maybe a biopsy, that's what we need in this instance to find out, of those people long COVID, who has persistent virus and how do we get rid of it.
I hate to do this, Dr. Koroshetz, because I am just really fascinated with what you're providing us.
Okay.
We have 2 more minutes.
Okay,
I hate to do that because I'm just,
okay.
thank
Yeah.
you.
Oh, okay. So let me just skip then. So there's a whole bunch of studies going on these different, to test these different hypotheses for the cause. But in the meantime, we launched a series of clinical trials that would look at the main symptom complexes that cause trouble for people. So we have trials on the autonomic trouble, trials on sleep trouble, trials on improving exercise, and trials in improving your cognitive abilities. And we have a set of trials that could test the drug that would get at the underlying cause. So we have 5 different platform trials that could test multiple things over time to understand how to best help people. And so those are seen here. Again, these were designed because these are the things that people complained of the most. And so this is just to sum up. Recover is looking at over 60 million records. We have 30,000 people enrolled in in-person studies. We have 197 autopsies. We have 8 trials testing 13 different interventions right now. And a lot of this data is, because it was a big effort, is, being analyzed now and will be coming out shortly. It's all data will be public in what's called Biodata Catalyst, so anybody can start analyzing it. And with that, I just want to end and say, we're really invested in trying to figure this thing out, and really also trying to get help for people who are having symptoms right now that impairing what they want to do with their lives. So thank you very much.
Thank you very much. I'm just so fascinated with hearing when you talk about, especially how we looked at after death. What are we seeing, after death? What is still around in tissues? How is the damage done afterwards that we can't see, obviously, when someone is with us? So I'm just absolutely fascinated by your work. And what I'm going to do, because time is running a little short, what we will do is anyone has questions, and I did put it into my email into the chat. Please forward me any questions you have. And Dr. Korschetz also had his email that was on the screen. And I will forward any questions to him as well about the material he covered, because I'm sure there's lots of things that people are thinking of as we're going through all the data and all the information, that's been collected over the last 4 years, since this pathogen was first seen.
Right.
So I thank you so much, sir. I really appreciate all the work that you've done, doctor. Thank you.
Sure thing.
Okay, so what we're going to do now, we're going to talk to Dr. Catherine Sequelae and Becca Squires. Dr. Sequelae is an associate professor in the Department of Physical Medicine and Rehabilitation and clinical neuropsychologist. She's the director of the Traumatic Brain Injury, or TBI, Rehabilitation Program and co-director of the Post-COVID Conditions Clinic. She received her PhD from the Virginia Consortium Program in Clinical Psychology, completed her clinical internship at the Rusk Institute of Rehabilitation Medicine at New York University, and her APPCN Neuropsychology Fellowship at the Rehabilitation Institute of Michigan. Since joining the University of Michigan, she has started an adult concussion recovery program, incorporating both brief assessment and biopsychosocial intervention, developed a transdisciplinary post-COVID clinic, and has collaborated with physiatrists, neurosurgeons, critical care physicians, and others on improving care continuity for patients, with an emphasis on research to understand persons. Her research interests are primarily in areas of psychosocial, cognitive, and quality of life outcomes following TBI and concussion, outcomes after COVID-19 and critical illness, and improving collaborative rehabilitation treatment. Becca Squires, or LMSW, is a clinical social worker at Michigan Medicine, currently working in rehabilitation psychology. Currently, her role is both clinical group facilitation and program coordinator for the post-COVID and concussion clinics. Becca facilitates their 6-week COVID recovery groups, bringing psychotherapy tools, interventions, and skills to patients who have experienced debility and disengagement as it relates to their post-COVID symptom experience. In addition to patient care in her role as coordinator, she spearheads their internal processes and outward-facing resources related to their post-COVID clinic. She also facilitates a concussion recovery group and FND wellness group. Her clinical and research interests include behavioral interventions for symptom improvement, as well as change management and improving patient experience throughout their healthcare experience. Welcome, Dr. Sequelae and Becca.
Thank you so much. Becca, would you be able to slide share? While Becca's setting up the slides, I just wanted to thank you so much for having us. We're really honored, I think I speak for both of us, to collaborate here with Disability Network. I'm very involved with Disability Network here in our home county of Washtenaw, and I'm just exceedingly impressed with the work that you do to advance independence and to advocate for inclusivity for persons with disabilities. So we're just really happy to be here with you. We're going to be talking about supporting patients with post-COVID conditions. Next slide, please. So just briefly, we're going to define post-COVID conditions. It's a term that some might not be familiar with. Everybody knows long COVID, but we'll talk a little bit more about why do we say post-COVID conditions. We'll introduce our own clinic model here. I'll talk a little bit about the biopsychosocial model of post-COVID conditions that we use here in our clinic. And then Becca's going to really drill deep with some details of the evidence-based interventions that we use here. And then we're going to go over a little bit of our patient feedback. Next slide, please. All right, so post-COVID conditions. We call these by many names, including things like long COVID, long haul, post-acute COVID-19, post-acute sequelae of SARS-CoV-2 infection or PASC, long-term effects of COVID, chronic COVID. So these are all really referring to the same thing. We use the term post-COVID conditions for a couple of reasons. One, it's one of the preferred terms from the CDC. But two, I like it because it really acknowledges that this is a group of conditions. It's highly unlikely that it's one thing, and that it's very individualized from one patient to the next. As you saw in the last presentation, there are many different symptoms that patients can experience, and oftentimes they experience a lot of symptoms. No two patients' experience is exactly the same. And so we really like this term post-COVID conditions. You have to be at least 3 months post-infection to meet criteria. And this, again, as I said, refers to a wide range of new, returning, or ongoing health problems that people might experience after being infected with the virus that causes COVID-19. Again, very individualized. Next slide, please. What are the most common symptoms that we're seeing right now? Fatigue is number one. We also see a lot of patients who report brain fog or something similar like memory or other cognitive disturbances, autonomic dysfunction, headache, or other diffuse pain experiences, smell or taste disturbance, myalgia, anxiety and depression, and even some post-traumatic response similar to PTSD. Heart palpitations, and decrease in functional capacity, either physical difficulty kind of moving through life or more overall difficulty moving through life and functions. Next slide, please. I'm going to circle back to this slide once again, but I just want to briefly touch on where is the research headed right now, and give you kind of a snapshot of that so that you can really appreciate why we focus on what we're focusing on in our clinic. So you can see here, if you go to clinicaltrials.gov today, and this is different than it was, say a year ago, the vast majority of the trials are really focusing on things like exercise, behavioral interventions, rehabilitation interventions, and education. We've really moved away from this idea that we're going to have a pill or a magic wand that is going to make everyone better and solve this problem. One, because we had some trials that have tried that and it hasn't worked. And two, because we want to give patients something that they can do right now to help improve their daily function and quality of life. And we have a lot of good treatments from other chronic conditions that fall into these categories of exercise, behavioral interventions, rehabilitation interventions, and education that we are able to transfer over to our patients with post-COVID conditions. Next slide, please. So we acknowledge in our clinic there are many unknowns still, but that doesn't mean we should twiddle our thumbs and not help people. We are having increasing knowledge that a strictly medical treatment model is not optimal. So finding some magic pill, finding some magic procedure, medical procedure that's going to make everyone better, it's not really looking like that's happening anytime soon. And so we really emphasize the biopsychosocial aspects for addressing lingering symptoms. And I'm going to talk more about that model in a little bit. Our primary intervention is a 6-week group that's focused again on education, behavioral rehabilitation, self-management strategies, and coping skills. Next slide. We couple this group with some visits with our other providers. So myself, I'm a neuropsychologist. Dr. Josh Startup, he's a physiatrist who specializes in brain injury medicine, but has gotten very involved in post-COVID care as well. And our PA, Crystal Martin, who also is trained as a physical therapist. And so she really has a nice, unique perspective that can assist with these patients. We see that our patients come in with a lot of uncertainty surrounding their symptoms and prognosis because this is still a relatively new set of conditions. And so we want to address this uncertainty by providing them with some practical, pragmatic tips and treatment recommendations to address their specific set of symptoms. We, of course, provide or assess for need for appropriate or additional referrals from their PCP. So we're always working closely with their PCP who provides them with more long-term care. We discuss with them specific lifestyle and behavioral interventions to improve their current functioning. And we really, with all of these recommendations, are trying to improve or increase the internal locus of control. So helping people feel like they really can engage in some strategies to manage their symptom experience. Next slide. We have a team-based care approach. So patients come through the door with Becca, who you're going to hear from in a little bit. And they have their consultation visits then with our medical providers. Oftentimes our patients report a large disparity in their initial workup for their symptoms with their PCP when they mention COVID. So what I mean by that is when they say COVID, sometimes they feel dismissed by their PCP. They feel as though their symptoms might not be taken seriously and that they don't get the thorough medical workup that they need and deserve. And so we look for the holes in that workup in our clinic, and then we write a report that goes back to their PCP and we say, please address these holes. Please do this additional workup. In the meantime, we're going to focus on symptoms and function, but here are the other things that we want you to do. If indicated, the patient may have a comprehensive neuropsychological evaluation depending on their symptoms. Of course, that core piece of the clinic is the group. And then afterwards, patients have the opportunity to follow up with Becca again to make sure that if there's anything we missed, if they need recommendations for continued care, if they need additional supports in the community, we can help figure those things out before they leave our clinic. Next slide. I'm not going to talk too much about this slide. I just want to bring to your attention, we also use the PASC guide. This is a resource, an online resource that anybody can access that includes guidance on managing post-COVID conditions from clinician researcher experts in the field here at University of Michigan. Next slide. So returning to this biopsychosocial, and I added experiential in here as well to really highlight patient experience. This is really the model that we are using within our clinic to understand what might be driving patient symptoms and thus to focus our treatment targets on those factors that might be driving symptoms. Now, of course, we have these biological factors. So the acute infection or inflammation that occurred from that infection, perhaps some ongoing immune changes, perhaps altered respiratory patterns. So we include all of those biological factors that I think were an initial focus of research and treatment for post-COVID conditions, but we've broadened the umbrella. So we've said, yes, and there are some social factors, including, we all experienced lockdown, and that was traumatic, and we had some loss of roles. And we probably didn't have adequate social support or coping strategies to get through the trauma of the pandemic itself, or the traumatic experience of having had COVID. So we really focus on some of those social factors, some of those experiential factors, and psychological factors as well. And I like this figure because it shows these different groups as gears, meaning if one turns, it turns the rest. And so none of these things are acting in isolation of one another. And so we really don't think it makes sense to focus on, say, an organ-specific approach, or really just honing in only on the biological factors, but thinking of a holistic approach that addresses the whole person, including their experiences and some of these social and psychosocial factors. Next slide, please. So just returning to the clinical trials page, you can see here that our approach in clinic is really lockstep with the direction of the science in terms of how do we treat these conditions right now. Next. I'm not going to go over this whole slide here because I want to give Becca some time to dig a little bit more deeply into these interventions, but this is just an overview of the 6 sessions that we cover in our group intervention. Next slide. And here's Becca.
Hi, good morning, everyone. Can you hear me? Okay, good.
Yeah.
Yep. So yeah, I am the facilitator of our post-COVID recovery group. And so, a lot of what Dr. Sequelae shared is kind of leading up to our main intervention. And so I'm going to give you a little bit of a snippet into that. Then we have some feedback from patients, what they have given us in terms of their thoughts and reflections after they've completed group. And so, yeah, going to jump right into that. So some of the things that we talk about specifically, we start with the spotlight effect, right? Just the recognition that this diagnosis with acute COVID plus their post-COVID symptoms, plus, the worry and the uncertainty, isolation, all of that can kind of contribute to some of that, symptom burden, brain fog, fatigue, where we notice difficulty focusing, increased worry, difficulty sleeping. And so we talk a lot about how do we diffuse that light? How do we shine light on other things that are value added? One of the ways that I'll do this is actually ask someone to just describe their day. How does your day begin and end? And the frequency that they notice their post-COVID symptoms impacting their life is generally an aha moment and a good way to kind of get that connection between patients. The group normally has about 10 to 12 people. And since it's not a support group, we don't do a long introduction. We don't do a big kind of get to know you. So this is a good way to sort of anchor that engagement. We talk about spoon theory, which I'm sure is very familiar to many people who are connected with the Disability Network. Patients really resonate with this. Normally, I'll ask if someone has experience with spoon theory, if they have had chronic illness prior to their post-COVID symptoms. And again, it's another way of getting expert experience, shared by group participants, but then we elaborate on some of the unique pieces that they're experiencing within their post-COVID symptoms. We talk a lot about recovery. And so 2 of the tools we use a lot are this graphic. And I just share with patients, that this might be a different type of recovery than what they're used to. If you have a shoulder surgery, for example, or some other, acute surgical procedure, there might be a really linear pathway to recovery. Whereas in this place, they're kind of having to one, acknowledge the tiredness, the rest, losing fitness, movement is more tiring, so I rest more, right? This becomes a little bit of a spiral. So we talk about each person finding their own place where they can interrupt this. Can rest mean laying down instead of sleeping? Can movement mean going to the mailbox instead of asking my spouse or child to? Really small ways to interrupt some of these cycles. And then normally at least 1 or 2 patients share that they feel their symptoms are cyclical. They feel like they can't find a pattern or a pathway. And I'll just kind of share this graphic in the background as they're describing their experience, and they'll say, oh, that's me, I'm booming and busting, right? The idea that I have a really good day and I do too much and I overextend because I'm trying to catch up and I'm trying to, get back to that normal, quote unquote. And then they have these really low lows. And so recognizing that this actually is decreased functioning over time, we feel worse. And so I forgot to include the graphic about what it looks like to be recovering, but it's higher lows and lower highs. It's really having a little bit more of that middle of the road every day or every week and seeing that improvement slowly over time. We talk a lot about sort of isolation, reducing isolation, recognizing that changing our behavior is really difficult. There's always an emotional component to that. So I actually use the COVID recovery group as an example for sharing, there will always be this little peak of anxiety on that blue line. You can see the emotional response is kind of high, but over time, we know that it will go down and that we will have that sort of emotional response with less intensity each time we engage in a behavior. But that red line of avoidance behavior, if you log in and you're feeling really uncomfortable and really anxious and really, intense emotions, and you don't allow them to pass, they'll just continue at that level. And it really starts to impact things like social connections, ability to seek out or engage in employment, and all of the things that are, really important for our feeling human, right? Our humanness and our values-based activities. We talk a little bit about thinking traps, which is a pretty common kind of cognitive behavioral therapy concept, cognitive distortions, but we also talk about ACT and the ACT triflex, where sometimes it's a cognitive distortion, right? Everyone is talking about my post-COVID symptoms. Everyone is talking about me behind my back. Well, that might not be true. But what if there is a thought that is unhelpful but true? How do we move through that? And so we use this model a lot, being present, doing what matters, and opening up, and talk through these steps with patients. What do I do when it's a cognitive distortion? And then what do I do when it's not? Because I think it all starts to feel true if that is the burden on day-to-day life, right? Both the emotional, the physical, the sociological, and then the, spiritual as well for some patients. This concept is really helpful for patients that experience shortness of breath, increase in anxiety, and especially patients that had a period of really concerning acute illness at home. People share, I was sleeping in the guest room, my spouse was checking on me, they were hoping that I was still breathing. Really, really, can be serious emotional burden to those experiences. And so we talk about I usually encourage patients to start with the thinking kind of bubble. So think about our anxiety, feelings of panic. We tend to reflect on some of those memories in the past, worrying about dying, misconceptions about our functioning, and then that sort of starts to spiral. And then we experience that reduced activity. We isolate, we need more help from others, and we actually experience some of that deconditioning. And then our breathing is impacted, and it can impact our respiratory rate, our accessory muscles. We're doing increased work of breathing. And so shadowing, I guess, reflecting back to the graphic that Dr. Sequelae shared with those cogs, right? I also imagine these three as cogs that kind of impact each other, right? Once we get going down one circle, they all start to spin. And I think that can be really difficult to interrupt if you're not aware of that pattern. So we talk about this quite a bit as well. This is just kind of the description of that model. We also talk about sleep hygiene. We talk about progressive muscle relaxation, mindfulness versus relaxation versus deep breathing. We talk a lot about goal setting, and a lot of what patients share is also goal setting and boundary setting. If my roles have changed, if the ways that I receive help have changed, then I need to also consider my boundaries and what sort of support I'm letting in and what type of boundaries I'm setting in other settings as well. And then we talk about behavioral activation as well. The first homework assignment, one of the first things we encourage patients to do in group is do something enjoyable. And it is always refreshing to see and to hear them in week 2 sharing, I went out for a walk, or I got my nails done, or I did something. It can be really big, it can be really small. Most of them are pretty small activities. 1 spoon is kind of the phrase that we use. But just how do I get back to some of that functional engagement with life? And again, what makes me kind of feel like a person, not just a patient or someone who's unwell. We send patients a qualitative survey afterwards. It has 2 questions. One of them is, what was the most helpful tool? And the other one is, how has this impacted my recovery? Asking about the group specifically. Pacing comes up so many times. Recognizing, symptoms may or may not resolve. What can I do, right? Dr. Sequelae mentioned the locus of control, and we talk about that almost every week. And then, just the validation of being in a group with others. So, I will stop sharing and see if we have just a couple of minutes for Q&A.
Yeah, absolutely. Dr. Sequelae, did you want to answer the question?
Yes. So that was an excellent question about post-exertional malaise and whether or not, how do we address that, and whether or not 6 weeks is enough. So of course, 6 weeks isn't enough to address any of these things thoroughly. And we acknowledge that, and we set that expectation the first time we meet with patients, that we're not here to pretend that we can just fix everything within the context of this clinic and, tie it up with a nice bow and send you on your way, and you're going to feel exactly like you did before you had COVID. That's not the idea. We have to set reasonable expectations about, we're going to give you some tools, and we're going to practice those tools with you for the next 6 weeks, and we're going to help you fine-tune your approach. And we're going to give you, some homework between each visit to make sure that you're practicing and that you have the opportunity to develop these skills within the safety of this clinic. And then we're going to send you out into the world, and you're going to continue to use and refine these skills and tools to manage your symptoms and continue on your recovery journey. Now, that doesn't mean that, okay, we're never going to talk to you again. You can also reach back out. We had patients who've done the group twice, if that's what they wanted to do, and they felt like, I've been doing this. I've honed my skills, but I think I need a refresher or a booster. That's perfectly okay. But yes, there is no expectation that we're going to fix post-exertional malaise or any other symptom within a 6-week time frame.
The other thing I'll add to that as well is that I encourage patients at week 1 to have this. Technically, it's 5 weeks, right? From week 1 to week 6. This should be your trial and error, because I think a lot of patients share that they have been trying, or they think they've been trying to do some of these things, and they would like to have a period of testing whether mindfulness or sleep hygiene will make a difference. So I really remind them that we're in this, right, present focus thinking. And then sometimes that's what our return visit, that kind of wrap-up visit, looks like with me, as I say, what was helpful, what was not helpful, what is our treatment planning moving forward. And also, typically they have at least one of the remaining 3 visits with our physician assistant left. And so that is a touch point where we also check in, and they're filling out, some symptom questionnaires, but also, we can circle back if they feel like, my mental health pieces are really spiraling, and can I reach back out to Becca to get some community therapist resources, things like that.
I'm also, let me see here. Is there a question? Oh, no, just, okay. So I wanted to also add, I know we talked about some of the qualitative patient feedback, but we are collecting, as Becca alluded to, quantitative data as well. So structured symptom assessments over time. And so we look at these both before, at the beginning of clinic, and then kind of throughout clinic. And then we try to reach back out and see how patients are doing a number of weeks post-clinic. And what we're seeing is that the symptoms that we are specifically targeting in our group intervention are improving. And so it's great to get the qualitative feedback. We love to hear from patients in their own words, but we are doing that more quantitative research as well, because we want to know if what we're doing is helpful, and if not, then of course we would we would change course.
Great. Thank you so much for that wonderful information, Dr. Sequelae and Becca. It's really appreciative and hearing what the work that's being done at the post-COVID clinic and what it looks like to as vulnerable as you feel as a patient, to have to go through and say, I need help and I don't know what to do or what direction to go. And the work that you guys are doing are very thankful for that. And I'm grateful that you guys are here today to discuss that too.
Well, thank you again so much for inviting us. And, if you're a person who is experiencing a long COVID condition, or if you know somebody who is, or if you're a provider who's working with some of these patients, feel free to send them our way. And we'd be happy to meet with them and see if our clinic is a good fit.
Yeah, Marissa, I sent you the post-COVID clinic email. This is the general one that's on our website, but I actually respond to those inquiries. So I'm happy to discuss if a patient referral is appropriate, if, how they can access the forms. Feel free to use that email, and you're getting kind of touch point with me if they reach out that way. Yep.
Awesome. Thank you. And the information you did send to me, people that are hearing that too, that'll go out to you at the end of this week. So that this is a lot of information to go through. So we want to make sure too that when we leave here, you see what direction, where can you get more information from? How do you approach? Where do you come from, and so on? So absolutely. Yeah. And thank you, Becca, for sending it over to me as well. So we heard a lot of information today. We heard about the application of large data, on mitigating the symptoms and sequelae of this brand new pathogen, especially if you're not familiar with how everything unfolds with having a pandemic and everything was unfolding on the world stage. So this may have been brand new to everybody of how does research fit into this? How does something keep changing from one moment to the next? And you got to see through all stages, from person being sick to after a person, there were some of their symptoms, may have lessened, or unfortunately the people that have died from COVID. What does the tissue look like after that? So all of this feeds into how can we treat, how can we mitigate, how can we help people through COVID, and of course any residual or these symptoms that last for some. And we want to, definitely try to help people and advocate for people as best as we can, and encourage people to ask questions. That is incredibly important. And as a Center for Independent Living, it is important for us to help you with those questions and help that which direction that you can go. So I do want to say thank you, to all our presenters, Dr. Walter Koroshetz, Dr. Catherine Sequelae, and Becca Squires. Thank you, absolutely, for all the information you provided. Thank you for participants for attending. And I hope to see you tomorrow. This is our first day. So I hope to see you back tomorrow at 10 o'clock in the morning, Eastern Standard Time, for day 2 of Let's Talk Long COVID. Tomorrow, we're going to hear from Dr. Zayed Al-Ali on long COVID with veterans. And we're also going to hear from Krista Coombs and how to advocate for ourselves and others. So we're getting all this great information, and we want to encourage you to walk away and with action. What can you do with this, and where can you take this? So if you have not registered for tomorrow, go to our website for Disability Network West Michigan. You want to click on events, and you're going to click on tomorrow for the 22nd for the corresponding event, and register, like many of you did today to register for today's event. And just to remind you, all the resources that has been sent to me will be sent on to you at the end of the week, because I want you guys to be able to look over as well the information all these wonderful presenters have provided, so you can see it as well. So thank you again for attending. Thank you to the presenters for taking the time and just going over all the wonderful expertise and the leadership that you have, and sharing it with all of us. And then you guys have a wonderful day.